Hello student doctors, welcome to my CPR2 lecture called Drugs to Treat Hyperlipidemia. My name is Jeff, so let's get started. For your learning objectives, we're going to discuss the common classes of drugs used in the treatment of hyperlipidemia, including for each drug, all of the following: mechanism of action, indications, will be brief, contraindications, adverse effects, cautions, warnings, black box warnings, and metabolism. Statins, ezetimibe, PCSK9 inhibitors, bile acid sequestrants, fibrates, and niacin. Statins are a class of prescription drugs used together with diet and exercise to reduce blood levels of LDL. For further reading, hyperlinks I've embedded. There's 3 of them. It's worth pointing out here that these drugs are huge moneymakers for the pharmaceutical industry, approximately $14.5 billion a year. These drugs use the liver to block the body's creation of cholesterol. The problem is a number of studies have linked these drugs to an increased risk of these potentially serious injuries, including muscle damage, kidney problems, and diabetes, myopathy, especially muscle injury. The most severe form of myopathy is called rhabdomyolysis. In patients, this will lead to severe kidney damage, kidney failure, and even possibly death. What these drugs do is they competitively block the active site of the first and rate-limiting enzyme in the mevalonate pathway. It's called HMG-CoA reductase. So inhibition of this enzyme prevents substrate access, blocking the conversion of HMG-CoA to mevalonic acid. So there are several non-lipid lowering mechanisms of actions of statins, including plaque stabilization. They reduce inflammation. They also reverse endothelial dysfunction, and they decrease thrombogenicity. These drugs are marketed as single ingredient products, as combination products, with extended release niacin, as well as together with ezetimibe. These drugs are intended to prevent cardiovascular disease. Considerations for the safe use of statins. If you click on this link, it'll take you to an AAFP article. It's a pretty good read. They're contraindicated in patients with active liver disease, also with unexplained and persistent elevations in aminotransferase levels. They're contraindicated in pregnancy and while breastfeeding. In this country, about 10% of patients prescribed statins stop due to subjective complaints. Oftentimes there's muscle symptoms without a rise in creatine kinase. This is in stark contrast to randomized clinical trials where the evidence of muscle symptoms without enzyme elevations due to statins is less than 1%. But all of them have been implicated as causing myopathy. It's always bilateral and always symmetrical, always confined to skeletal muscle. Newly diagnosed or new onset diabetes, a potential causal relationship between statins and the risk of developing diabetes, which is kind of liver function in about 1% of patients, is it does not indicate either hepatocellular injury or liver synthetic dysfunction. And ALT is always greater than AST. It's important in distinguishing liver from muscle-related AST. Neurologic effects. There's an inverse relationship between cholesterol levels and the risk of hemorrhagic stroke. Data shows no increased gain of primary prevention population. Forgetfulness and other mild cognitive impairments, which are common in older adults. Again, available evidence indicates that statins do not increase the risk of such disorders. There is an association between the development of peripheral neuropathy and statin use. Here, a few animal studies suggest the formation of cataracts, rhabdomyolysis, and subsequent myoglobinuria. The adverse effect on renal function is more likely in patients who are on higher doses of statins, amongst patients with known interacting medications on board as well. So in folks without this rhabdomyolysis, statins do not cause kidney problems or worsen proteinuria long term. Tendon injury can occur. All of these reports are observational, and there's really no consistent difference between users and non-users. Actually, no good evidence to suggest that statin use increases tendinitis or tendon rupture. All statins undergo hepatic first-pass metabolism, thus they are not very bioavailable. Pitavastatin has the highest bioavailability at 50%. Here that simvastatin and lovastatin are administered as prodrugs. This increases their extent of hepatic metabolism. The following is a very important aspect of drug metabolism. Drugs which undergo a lot of first-pass metabolism are very often vulnerable to drug-drug interactions. as well as food drug and herb drug interactions, student doctors. These are all mediated by cytochrome P450 enzymes. The effect of statins on the body is almost universally affected by concurrent metabolism of other drugs which induce or inhibit P450. Rarely do statins affect the metabolism of another drug. The one known exception is the effect of some statins on vitamin K antagonists. For example, warfarin will often require a dose reduction when given alongside statins. Age and ethnicity can have a big effect. These drugs are some of the most heavily studied drugs in the world. In older folks, the risk of myopathy is about twice that as younger folks. East Asian populations are generally prescribed lower doses. They're more sensitive to these medications, or they have an increased therapeutic response when compared with Western population. PK studies do suggest greater plasma concentrations in East Asian populations. Clinicians should remain aware that East Asian folks have the possibility of having a greater sensitivity to statins in general. Here's where some of the controversy over these drugs comes in. There is no black box warning, and the FDA indicates that it does not see a high enough risk to warrant that. This suggests the FDA fears the warning may scare consumers away from using statin drugs. And here's a safety statement given by the FDA. So you can see here, FDA Drug Safety Communication, important safety label changes to cholesterol-lowering statin drugs. All metabolized through cytochrome P450. Lipitor, Zocor, Altacor, Mevacor go through CYP3A4. Fluvastatin is metabolized primarily by CYP2C9. Okay, student doctors, that's it for statins. One of the more frequently prescribed drugs you will encounter in your clinical career.